Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 217 of the Better Health Guy blogcast series. Today's guest is Dr. Robin Rose, and the topic of the show is addressing the kidneydemic with Renology. Dr. Robin Rose began a journey into holistic healing in her teens in the mid-60s, beginning with nutrition and botanical medicine and yoga and meditation. Over the years, her journey included time living in India and working with both village doctors and healers. She became a health food chef and inspired many to change their habits. Before long, she was enrolled in a nursing program and then a family nurse practitioner program. Aware that the education wasn't complete, she attended University of Arizona College of Medicine while also serving as a medical student board member for the American Holistic Medical Association. During residency, she continued learning Chinese medicine, acupuncture, osteopathy, energy medicine, and herbal medicine. Her main practice was in Ashland, Oregon, where she served a community eager to integrate many healing modalities into the conventional setting, including innovative care in the hospital. In the past decade, after her own alarming health challenges with kidney cancer and advanced kidney disease, she became agile in regenerative medical approaches to kidney care. She created a new specialty called Renology, a new concept of kidney success, not kidney failure. When she discovered peptides and especially bioregulator peptides, she led the brigade to new heights of seeing success in a field that had not embraced this kind of care. Her recent book, Renology Peptides, is a nearly 800-page text on how to achieve this renewal of health. Her current intention is to raise awareness of the role of kidney in well-being and how we can all celebrate this success. In part one of our conversation here in episode 217, we talk about Dr. Rose's personal kidney journey, symptoms of kidney disease, the primary functions of the kidneys, stages of kidney disease, lab testing, phosphorus and potassium, gut and metabolic health, endothelial health, and mitochondrial health. And in part two, in episode 218, we talk about infections and toxicants, carbon dioxide, uric acid, cognitive health, cellular senescence, the limbic system and mental emotional contributors, dental considerations, treatment interventions, peptides and peptide bioregulators, and much more. And now my interview with Dr. Robin Rose. Renology is the art and clinical science of kidney success and is what our guest today calls early bird medicine. She says that we want to approach the kidneydemic with the audacious intent to heal and a focus on turning vicious cycles into precious cycles. In fact, she wrote a nearly 800-page book. I don't have to go to the gym today, do I? Her book is called Renology Peptides, and this is such a critical topic. Clearly, there is a personal path, a purpose, a journey, a passion in the work that she does. Thank you for being here today, Dr. Rose.
Thank you so much. I'm so glad to see you.
Talk to us a little bit about your personal journey with your own kidney health and how that drove you to the passion you have today, probably the world's leading expert on kidney health. And then as you walk us through your story, and we'll talk more a little bit later about why GFR may not be the best or only marker we want to look at, but talk to us about when you actually had your kidney removed compared to today, what your GFR was, so that we can kind of give people some hope that are dealing with kidney issues.
Yep. Well, first of all, I've been basically non-conventional family physician for a long time. And to be honest, as thorough as I thought I was, in retrospect, I really didn't know hardly anything about kidney. And that's having practiced for decades. I thought I was doing a great job in helping people in that regard. I had a series of mishaps in my life, in the Holmes Rahe stress points. I was high on that list, including my medical practice being embezzled. I mean, it was a lot of stresses. And so I downsized. I tried out a few things, basically decided I'm old enough to just stop doing what I'm doing. And long and short of it is, I was in Hawaii and got norovirus, which is one of those unpleasant barfing and pooping extravaganzas, and basically never got better. And so I eventually started spiking high blood pressures, which I was the, health food Hannah with the blood pressure of 90/50. And so it seemed to me, I mean, at the time I thought it was going to be an adrenal tumor, which is benign. It's like, well, I don't know what's going on, but something, because I was spiking pressures like to 220/110. This is like stroke level scary stuff. And I went and saw someone who had been a pulmonologist who became an integrative doctor and really kind of missed the boat. She was trying to be nice and integrative, and she was like, repeat after me, I am healthy. And I used a Jersey girl word I won't repeat now and said I would like a CAT scan, and was diagnosed with a left upper pole renal cell carcinoma, a rare variety of it, but it was well circumscribed. I meditated, prayed, and researched, and really wanted to do a nephrectomy. I wanted this thing out. It was just really clear. And so 3 weeks after this major surgery, I mean, losing a major organ is not a trivial thing. And the dharma in the conventional medicine world is that you're fine with one kidney, no problem. And for many people, I'm sure that's probably true. However, 3 months post-op, I went back to Oregon where I'd had the surgery and did a follow-up, and came to find out I was right at the border of stage 4, which begins to be severe kidney disease. And I was alarmed. I really wasn't doing well. And yet, that the people I was seeing was like, I mean, really just neglectful, false reassurance, because I wasn't feeling well at all. And so that began the odyssey, because I was basically, on one hand, don't worry, people live for a long time with this. And I was like, well, how do they live? I'm into wellness and this doesn't feel very good. And on the other hand, when will you be ready for us to install plumbing for dialysis? And none of that appealed to me. I was like, wait a minute, this is something I need to know about. And hallelujah, I had a copy of the Townsend letter, which is an alternative thinkers medical journal. And I had this experience. I reached out in the moment of calling for help. I need someone who knows more than I do to help me, because I realized I really wasn't able, I couldn't deal with it. I opened it up to an article by Jenna Henderson, who's a naturopath whose practice is kidney. And she was a lifesaver, because the MDs that I'd been seeing, I'm like, well, what should I do? What should I eat? What do I do? Don't worry, was what I was told. And that's not medical care. That's never how I've ever practiced medicine. I mean, it was really alarming to me. Jenna was amazing and got me on the right track. And I sat in this very spot and started looking stuff up. And 10, 12 years later, I've gone from a GFR of 30 to a GFR of 68. And
a really big book.
a really big book. I mean, and I could have written 12 really big books with the amount of information I came up with. And, because first of all, you start with what I call the low-hanging fruit. Diet. I made major changes in my diet. Organic food, plant prominent protein. I had high potassium, so I had to learn what to eat. How do you deal with it? Alkalinizing with bicarb. I mean, there's so many things to do. That could be a whole volume in itself. Sleep is critical. And yet, so many people don't sleep well. And with kidney, I'm doing this kind of biblical study of kidney right now because it's ancient. And in one of the Psalms, it talks about the kidneys advise at night. And sure enough, like things like your blood pressure, instead of dipping at night, rise. People get up to pee, like too many times. So there's something about sleep and how the circadian rhythm gets messed up. I found peptides to help that. It's been quite marvelous. Then there's exercise. Too much, not good. Too little, also not good. How do you find the right thing for the right person? For me, gardening, some weights, the ocean. Toxins are huge. And so I went through a whole process through my bathroom and my kitchen and the garage. I have other people paint for me, all kinds of toxins matters to kidney. So, that's probably an encyclopedia right there. And then we get going with the supplements, which we know that there's so much research. They say, oh, there's no research, we can't do this. And, I'm working on another volume right now called My Kidney Garden to look at the botanicals that are actually in my garden that are beneficial to kidney. And so that's been added, and then a lot of supplements. I mean, I'm one of those that here, I'll show you my morning plate of goodies. Still take that. Some of these are bioregulators and bioregulator peptides. So that was all doing good. And I got my GFR up to 51, felt a lot better. My brain started working again. My muscles stopped deteriorating. I mean, there's a lot of things that happen in early kidney disease, even that gets ignored, which we'll talk about. But then I heard about BPC 157, which is an injectable peptide. It can be oral, but when it's systemically useful, like insulin is a subcutaneous injection. And I found it. I spent a month researching it and was incredibly amazed at the difference in my health immediately, and started getting into the whole peptide awareness and the research, mostly looking through the filter of kidney. And then one day I heard about Pilotax, which is an oral bioregulator peptide, opened the universe and resulted in my friend here, the book.
We'll come back and talk more about pilotax and some of those kidney bioregulators. You have said that in traditional Chinese medicine, the kidney is at the core of our ability to survive. So
Absolutely.
incredibly critical. So give us just a high level kidney 101 for people listening. What's the purpose? Is it entirely detoxification or filtration? What is it filtering? Does it have other roles like fluid balance or acid base balance, or you've already alluded to blood pressure? What do you view as the primary functions of the kidney?
Well, first of all, think about this. All of the blood goes through the kidney. I mean, constantly, all day, all night. And so first imagine if you can envision what a nephron looks like. I mean, the kidney is this beautiful little bean-shaped thing, and there's lots of little units called nephrons. All of the blood comes to these little units. First, there's these beautiful things, podocytes. So the glomerulus filters everything, every single thing. Then there's a system of tubules. And the way I like to think about it, and it's part of what I'm finding in my little biblical explore, is that it is the organ of discernment. In other words, all the blood is coming. What do I keep? What do I excrete? There's some symbology in terms of our spirituality and our emotional life and physical everything. So it's really, its goal is discernment. And in a world that's full of crazy and toxins, that's really important to have that. And so basically, what I'm working on now is that it's the tubules that are really the clincher. And in fact, what I'm learning is that in almost every case, the tubules are what starts declining first. And so even with glomerular diseases, it's these tubules. So if you imagine, it's similar to the small intestine, that the small intestine does a lot of metabolic decision making and breaking things down, creating things. So kidney also, there's transporters along these tubules. And that's the decision making. Do I keep this and put it back in the blood, or do I drop it into the urine so that it can be excreted? And so that's really like a meditation. You know, for me, I mean, I imagine this a lot. I sit and can I use this inner vision and inner hearing? And that's more of, in maybe the Middle Eastern tradition of kidney, which is also as strong as Chinese medicine. And so once the tubules start misfunctioning, then okay, there's filtration, but what's the downstream? And that's really the answer to your question, because there's all kinds of things that happen as a result of filtration not working, if there's scarring that happens at the glomerular level and scarring that happens at the tubular level, things that you should get rid of, you're keeping. That can be a problem. So what is the whole conversation? So what is a lot of metabolic issues, cardiovascular issues, mitochondrial issues? It's complicated, dysbiosis issues. And so, along those lines, we know that what we're exposed to, say, inhalable toxins, get in the blood, get through the kidney, and those tubules can be damaged by that. And so maybe we have excess of lead that wouldn't have happened if the filtration was good and our body knew how to get rid of this. And so there's consequences. And, you can do that with so many chemicals. There's another volume, I call it renal detoxicology. And that aspect is so critical to me in my thinking. When I talk with people about how they're doing with kidney, it's critical to spend a long time like, what are you drinking? What are you eating? What's under your bathroom sink? What do you do at work? And it's minimized to some extent in allopathic medicine. And so we have this role in protecting people. So the kidney is really our protector. It's about insight and intuition. And unfortunately, when it's in the pandemic that we see, there's a lot of people who really aren't getting rid of stuff that they need to get rid of. And there's ways to help it.
Interestingly, when you talked about the shape, I guess I now see why we call it a kidney bean, because it looks like the kidneys, right? I hadn't really thought of that before.
Yeah.
What are some of the common symptoms that we might see in chronic kidney disease? Maybe things we should be looking for that might lead us to consider a deeper exploration into our kidney health? And what are some of the conditions that are associated with chronic kidney disease, or maybe our comorbidities? How prevalent is kidney disease in today's world?
It's probably more prevalent than we realize, because the statistics are basically looking from stage 3 down. So just as a brief, there's stage 1, which is really, I almost ignore stage 1. I mean, the sensible stuff, low-hanging fruit, don't eat stupid stuff, make sure you sleep and exercise, blah, blah, blah. Stage 2 starts with 90 to 60 GFR. And I look at a GFR of 60 is 50% function. You think of like 120 is about the high end optimal. And so then we go to stage 3. There's 2 categories, stage 3A and 3B. That's becoming more of a moderate situation. That's basically 30 to 59. And, when you get to 30, that's 25% function. Below that, we have stage 4. People are getting way sicker. Stage 5, prepare for either dying or dialysis or transplant, or God willing, some strategies to repair that. And that is possible, though not practiced conventionally that much. The dharma is you can't get better. And I'm here to say, take that out of your limbic system. And so, yeah. So basically, with the earliest aspect of this, it's vague. And the conventional thinking is there's no symptoms. I've questioned large groups of kidney patients, like in Facebook kidney groups, there's thousands of people who are looking for help. And people do have symptoms, but as a family doctor, what we see, primary care, people show up with vague stuff. It could be any number of 1,000 different things. So it's really being attuned. Is this possibly kidney? Because the lab work may or may not really help us. So I'm getting to answer your question, but there's a little bit of a journey to get there. The GFR is okay. It's not the best lab. Cystatin C is another one that can help. But even so, when the tubules are going down, there really isn't lab work that we are using regularly. And I'm working on a presentation right now to change that, because there are some really lovely tests. And once I get that together, I'll be talking about it more. But at this point, what I can say is, if somebody has lupus, if somebody has high blood pressure, had a heart attack or a stroke, cancer drugs, toxin exposures that of, somebody who's a glass blower or whatever, working at an auto shop where they're breathing fumes. Those are all, what about kidney? And so people will present with things like, I'm fatigued. My face is puffy. My legs are puffy. That's usually more advanced, but I've seen that on presentation as well. My skin's itchy, because that's a thing that will show up with kidney disease. And so, it's kind of vague. If you got a diabetic, assume it's time to address kidney protection. And you can talk about prevention, like if people don't have anything yet, protect your kidneys. You lose them, you're in trouble. And then you work on into kind of secondary prevention. Well, okay, we know there's some decline. Let's add some strategies, and on and on.
So, as I understand, conventional nephrology isn't really interested until the GFR is below 30, which is already stage 4 or 5. And I think one of the key messages of your work is we don't want to wait until we're stage 4 or 5. We can do a lot more earlier in this process. But one of the questions that I had was, even the staging for GFR, they say that anything greater than or equal to 90 is considered stage 1 kidney disease, which seems a little odd to me, because that kind of suggests that everyone has kidney disease. So what additional criteria have to be met to get a diagnosis of kidney disease, given what I just mentioned around that staging criteria?
Yeah, that's really a good question. I try to think of it more as insufficiency or decline, because disease has like a oof. And my own oncologist basically was like, do not use the word failure. You're not in failure. Failure is way over there. And I really appreciated that. Our limbic system hears these messages and the body reacts to what we are perceiving. And that's very real. There's loads of science about that. And, the limbic system practice is good for kidney people. So the thing that really bugged me was, and this is changing, the lab would say GFR greater than 60 is normal. So I have this, like, I'm going around saying stage 2 is not normal. It doesn't mean disease. That's like, ooh, disease. Well, if somebody has proteinuria, if they can't filter protein properly and losing it in the urine, that's a stage 2 issue, even a stage 1. Sometimes people have stones in stage 1 and 2. And so, okay, you're looking. There's some people I'm working with who have GFRs over 100, but have kidney issues and are diligently protecting so that the decline doesn't happen. Because I've seen some people who ignore everything I say, and they're fine, and they get a cold or some trauma happens, and phew, the function drops because there's no bolstering function and protection.
So, talking about then some of the symptoms that you just mentioned, one of the things that I'm curious about is when people have kidney stress, can they feel pain in the area of the kidneys, or can they feel referred lower back pain? I feel, and I've had kidney stress, and it's been a focus for me as well in the past year. And I feel like there's times that I can feel pain or discomfort in the area of the kidneys. And yet a very bright doctor told me that's not possible because the kidneys cannot sense pain. So do people feel pain in the area of the kidneys or low back when they're having kidney issues?
I was thinking as you were asking this, like, well, conventionally, it's denied. You don't feel that. On the other hand, I've talked to so many people with kidney issues who say that they have it. Are they making it up? I don't think so. There is referred pain and there is innervation. The tubules, if you have oxalate crystals going through, you're gonna feel something. I think that maybe some people are more sensitive to discomfort or, the frequencies in their body. Not everybody's paying attention. Those who do may be cognizant that something's uncomfortable. And I've seen people who had low back pain. It's like, let me look at your labs. Look at this. And it was missed.
Kidney disease is said to be a catabolic or breaking down process. So wondering if that catabolism is localized to the kidneys, or is chronic kidney disease an indication of a broader, more systemic breakdown? What are some other signs of breaking down? You mentioned in the book sarcopenia, or loss of muscle, which is also catabolic. So if chronic kidney disease is more broadly impacting the entire body, could we consider chronic kidney disease to also be an accelerated aging process?
Absolutely. And in fact, many people refer to it as a progeric condition. Progeria, most everybody remembers the picture. Here's, the 12-year-old who looks like they're 90, and so the way that I describe it is, people age. So, okay, you're aging. You notice things. I used to have all black hair. Kidney disease, that it's more rapid. I'm aware of that for my own self, despite the fact there's things to do, senolytics and, all of these things that we do to help kidney can can lower that slope. And it is a systemic illness. And that's where I came up with this idea of the vicious cycles. What came first? I never had high blood pressure until all this started happening. In fact, it was a little low, and some people have said that might have contributed to not circulating enough blood to the kidney. It is a systemic illness. And the vicious cycles are confusing, because now I have blood pressure that's consistently somewhat elevated. I think of the years it took me to figure this out. So now I take some supplements. I actually do take a pharmaceutical that I have compounded, very low dose, just to cover the bases. If a loud airplane goes by and it agitates me, I don't have to worry that something in my discombobulated system is going to be confused. But, it's like all of these things connect. And your questions are really good, because it's like if somebody has an autoimmune disease, you watch. It doesn't mean everybody with an autoimmune disease is going to have kidney problems, but they very well might. Why not do some strategies to protect? You protect the heart, you protect the eyes, you protect the brain. Let's include kidney in this wonderful idea. And so, personally, I got down to 82 pounds. I was a little panicked. And, muscle gone. I've worked on muscle, bone density, thank God, only slightly diminished. These are things you can work with. But, dental issues are way common. Eye issues are way common. and they say, like, okay, cardiovascular disease, anybody with cardiovascular disease, what's the kidney? It's a big glob of blood vessels. Basically, all these nephrons all have their own blood vessels. And so whenever somebody has cardiovascular disease, start thinking of kidney. And when somebody has kidney issues about, start thinking about cardiovascular, because it's a little vicious cycle. And that's why I say, let's turn these into precious cycles where we can actually protect.
Well, and one of the challenges I think with the kidney is it doesn't have quite the same ability to repair, at least more conventional thought. And I know with the peptides and peptide bioregulators, some things are shifting, but the liver is generally much better at repairing damage than the kidney, right? So, I mean, when I think of the two, I think we almost want to protect the kidneys even more because they're more precious because they have less ability to repair to the various insults that are happening to them. Would you agree with that?
Yeah, exactly. Yeah. I mean, you can reverse the fibrosis. I mean, so that's the cartoon of this is inflammation is the common denominator with every kind of kidney disease, no matter why it's there. That's an issue. And that leads to oxidative damage, which leads to fibrosis. And yeah, that's something that we know ways to deal with. And, short of adding more insults, because there's only so much you can do when you continue the toxins, you continue the stresses. It really requires a great deal of willingness to clear the stuff that hurts you to then achieve these ends. And not everybody's willing.
So I think it's already coming through, but just to be clear for listeners, when we're working then to improve kidney health, is the therapeutic focus targeted on the kidneys, or is it more broad, more holistic, maybe even more than just looking at the kidneys, looking at the entire body? And then we'll get into more detail as we continue our conversation. But what do you see as some of the most common root causes of kidney disease that are driving the modern kidneydemic?
Good question. Dysbiosis is very real. In fact, it's a unique uremic dysbiosis. It's even more interesting than just garden variety. Everybody has dysbiosis because there's toxins that accumulate because of the kidney decline that and causing disarray to the gut flora and to the others as well, oral and vaginal. And, I mean, it's a real part of it. So that's something that could be another volume because it's a big conversation. Mitochondrial decline is very intense and something that I encourage look at this in stage 2. The tubules are high-end mitochondrial compartments, lots of mitochondria. As they decline, that's where this transport need stops doing its thing. And so that's something. Glucotoxicity, an enormous hazard. And, I encourage people right off the bat, quit eating sugar, deal with it, figure out. I don't know how you're going to do it. And, we know diabetes is a huge contributor to the kidneydemic. And I also have been starting to tell people it's like back off from grains. It doesn't mean never, but every meal you have doesn't need to have a pile of noodles, a pile of potatoes, but you don't need all those carbs. And that really helps with the metabolic root of kidney decline. Heavy metals is well documented. And it's an interesting piece of it because there's disagreement about should you do heavy metal testing with provocation or not. And I understand both sides of that. And I'll share my story. I had a naturopath order a provoked and an allopathic physician order an unprovoked that I did the same time just to see. I thought, well, I got 2 kits. I'm gonna check this out. And the unprovoked one did not identify lead. The provoked one did. And I mean, first of all, there's no hormetic safe amount of lead. Every bit of lead is harmful. We know how harmful it is to kidney. And, here I was with blood pressure issues and I have a lead level. It's like, oh my God. Okay, I grew up in New York. I would go, walk down Fifth Avenue breathing bus fumes. I mean, I'm sure I was exposed as a youngster to a lot of leaded gasoline fumes. And, you think, oh, that's decades ago. Well, these things have a way of lingering. And also one of the things with that, this is just a sidebar, is when there is bone loss, which happens with kidney disease, and that's a whole nother conversation, because it's a unique form of bone loss. Here comes the lead that was stored in the bone. It's released systemically and starts causing problems. So, that's another one. So there really is a place for functional medicine skills using all of that, nutrient aberrancies, easy to check, I mean, a nutrient panel, mind boggling how many things can go wrong with one person. That's just fine tuning. Some of that is because these transporters aren't working. And so, folic acid and thiamine and niacin are all getting messed up. Those are easy fixes, cheap and easy.
So, when we do have kidney issues, is it largely from what's happening in this lifetime in terms of environmental toxicants and epigenetics, or is there a hereditary component of chronic kidney disease, or maybe even an ancestral trauma component that we need to consider as well? Talk to us a little bit about the role of genetics compared to epigenetics, or if those are not really common contributors to kidney disease.
Well, epigenetics is screamingly loud. I mean, that really is the conversation. There are genetic syndromes, and that's a whole another conversation. And identifying that, another sidebar. I believe that doing plasma amino acid panels is useful for some patients with CKD, and I found out that I had the amino acid abnormality for maple syrup urine disease. I was like, oh my God, I mean, obviously a trait rather than the disease, because, babies born with that don't do well. And, it gave me clarity that, oh, it's a good thing I'm not eating meat. And when I haven't liked it. And when I stopped doing, a heavy meat diet as a teenager, which was back in the 60s, I felt better. And so, so there's stuff to find at a genetic level that contributes to the bigger picture. But, the work that I'm doing is more focused on the epigenetics because, and we'll talk about this, but bioregulators basically hop in there and reverse epigenetic damage, which to me is stunning. It's like, wow. I mean, there's lots of things that do that, but this is like very specific for that purpose. And so, yeah.
So, I want to talk a little bit more about testing some of the lab markers. We talked a little bit about EGFR, which can give us some insight into the volume of blood that's being filtered through the kidneys. You mentioned that it is a useful tool, but there's so many others. Talk to us a little bit about how EGFR ties into creatinine. Is an elevation of creatinine another sign that the kidneys are not effectively clearing waste products? And are we using creatinine clearance essentially as a surrogate indicator of the kidney's ability to clear many other types of waste products as well?
Yeah, I mean, all that's true. The thing with GFR is it's a formula because, to actually measure that is expensive and not done, maybe in a research lab. But the way it's formulated is a guesstimate. That's the E, estimated glomerular filtration rate. And you watch it over time. So, what's useful is, oh, okay, I was at 30, now I'm at 68. That's useful. It was interesting when it got to 36. and I could assess clinically what's changed. How am I feeling differently? So it has a useful place. But think about it. It also reflects muscle bulk. And so somebody who's very bulky may have an elevated creatinine based on their physical presentation, and it's going to make you more suspicious of kidney. Okay, be suspicious. Keep looking, don't just go up. It's a number. I'm treating a number. We don't treat numbers. And so a very skinny little old lady could have a GFR that looks good because the creatinine isn't elevated. So that's a little bit of a confound that not many people put into their clinical thinking when they're assessing lab work. And that's why I like cystatin C doesn't do that. And sometimes I'll do them in tandem because it's interesting to be able to track how is that. Oftentimes I'll see someone looks like maybe they have some kidney decline, get a cystatin C, it's fine. Okay. Don't do stupid stuff to hurt yourself, more than let's be specific. And so the creatinine clearance is really useful in that regard. I mean, if I see an elevated creatinine, I'm going to raise an eyebrow and wonder, not make a whole disease drama out of it, but let's be protective.
So, given that GFR is a calculation that includes age, does that assume that the kidneys will always decline as we age? And should that be an assumption that we accept that decline? Is that normal aging? Or can we have vibrant kidney health long term if we treat them right? Is aging itself causing the decline, or is it the epigenetic and toxic insults of living in our modern world over time?
Got it. Yeah. So I'm sitting here watching my husband who's eating breakfast, who just got lab work yesterday. He's 72 and his GFR is 98.
Wow.
Right. So I tell this story often, but I'll tell it again. I was on a Zoom call with Joe Pizzorno, who's a naturopath who's written beautiful texts on toxicology, and Linda Frazzetto, who is a nephrologist from UCSF, who has really helped us all understand the acid base issue with CKD. And she's really open-minded because she actually has published with a naturopath, which is stunning. And she basically said, well, what do you expect? At your age, that's what you're going to have, is decline. And I love this. This moment was pinnacle for me because Joe said, but we do not monitor toxins as a conventional thing. We don't. And so you can't say that somebody who's lived a long time exposed to a bunch of toxins has kidney decline because of their age, but rather it's because of all of the toxins. I love that. That absolutely changed my mind and belief system about this. And I some of the naturopaths that I work with, there's another naturopath group in Australia, the Kidney Coach, Fiona Chin, is a dear friend of mine. We're doing a series of podcasts on each specific bioregulator related to kidney. And she's told me, they get people off dialysis and they actually reverse folks in remarkable ways. And so you're absolutely right. It isn't because of aging. However, if your lifestyle is replete with toxins, you may actually find that your aging is why, because you're not cleansing your lifestyle habits and doing physical cleanses to get rid of stuff. Senescence accumulates, and there's strategies for these things.
I have a coffee enema scheduled right after this conversation.
All right.
And then maybe touch a little bit on the issue with EGFR in the Black population, which might make things look better than their kidney health may actually be.
And fortunately, times change, and that's become, I tell people just ignore that. Make believe that doesn't exist. Cross that off of whatever you see. Because what it does is it basically doesn't diagnose people soon enough. because it falsely elevates the function status. And that's unacceptable, basically. And so thanks for mentioning that, because we're smarter than that now.
So sadly, what's in a traditional CBC or CMP, it doesn't seem to me that it really covers the bases, and maybe is a reason for why so many people are dealing with kidney disease, because they're so much further down the path before they kind of get some signal or insight to the fact that there's a problem. So wondering, what are some of the other tests that we might want to be looking at as kind of a functional medicine kidney function panel? Maybe the BUN, or blood urea nitrogen. Is there value in that BUN to creatinine ratio? You've mentioned there is some value in cystatin C. I know you also talk about your interpretation, which we're going to talk more about later, but that carbon dioxide could hold some value. You've already mentioned looking at higher levels of phosphorus and potassium, which we're going to talk about as well. So what are some of the more important kidney function assays that can really give us some useful insight?
I like looking at nutrient panels. I like Nutrival. It's so enormous. I mean, it takes a long time to actually really pick through all of that. Microbiome testing. It's not specific to kidney, but if you have a suspicion, is there something going on? Like you said, these are the root cause evaluations, I think, can be helpful. Mitochondrial assessment. Look for oxalates. Oxalates are an issue whether you make stones or not. So oat testing can be of value. There's some urinary tests that, like I said, I'm sort of evaluating. Beta 2 microglobulin urine testing can tell you that there's tubular abnormalities early. That's I'll probably do some blogging about that as I really sort of crystallize that for myself. With phosphorus, I like to see this panel, which would be PTH, parathyroid hormone, because PTH can become abnormal in kidney. So PTH, calcium, phosphorus, FGF23, which is a fibroblast growth factor. There are many, but this one specifically works with phosphorus. It's actually sort of protective when phosphorus needs a hand early on. Phosphorus may look normal on the lab, but FGF23 elevating is telling you phosphorus is doing its damage. And sidebar, what that is sucking calcium from the bones and putting it in the arteries. Two bad problems. And then the last one of that little panel that I'd love to see happen is 125 vitamin D, because they're all working together. And so those are useful things right off the bat. I like to get ADMA and TMAO levels, homocysteine levels, because they all contribute to the cardiovascular drama that is inevitable with most people with chronic kidney issues.
And is the BUN helpful, or is that impacted so much by dehydration and other factors that it maybe isn't a great screening tool?
Over sequence. If you see something once, it's like, maybe you're not drinking enough. Why don't you keep track for me? I like chronometer.com, CRONO, by the way. People can actually tell me, like, what are you doing? How much are you drinking? What, blah, blah, blah. And so it's useful in that you track over time. It's not as useful as some of these other things. Plus the intuitive idea that when you look at the comorbidities that really are in these vicious cycles, that's the clinical savvy. There isn't always a test that's going to tell you. I've been tagged as a skilled diagnostician because I was like, a little airy fairy, like, I got a feeling about this. I don't even know what that means. I mean, educated intuition. I've gone to school a lot. I read a lot. Whatever's coming at me makes sense. And that's what I encourage clinicians is, use your skills to say, I might be wrong, but I might be right. Let's explore a little bit.
So let's talk for a moment about a urinalysis, which is often, seems to me, done less than even a CBC or CMP. But wondering, when you see a high specific gravity giving us some indications potentially of dehydration. Does that lead you to thinking more about how to better hydrate that person? And how often do you see low specific gravity indicating overhydration potentially? And then maybe talk to us a little bit, and you touched on this earlier, but when we see protein spilling in the urine, what does that tell us? What is the urinary albumin to creatinine ratio? And can we even just observe the urine in the toilet and look for bubbly or foamy urine? Might that give us some clues as well?
Yeah, exactly. Good. Great questions. I love urinalysis. I mean, I think everybody should have one every time they go do lab work. There's a lot. I mean, there's a lot of indices. You can actually buy your own dipsticks and monitor yourself. You get them on Amazon, and it's not that hard to do, to self-monitor, self-empower. There's, from the UTI perspective, it's very useful. Is there Luke estrays? Something's going on. Blood in the urine. Why is that? With kidney disease, you can have that, but what else is going on? Protein in the urine is a bad prognostic situation with kidney decline. And so there are strategies to attend to that, lifestyle, basically. Some pharmaceuticals that aim at that. Certainly a lot of the botanicals and supplements we use can address that. What that means is, instead of having an adequate filter, it's leaky. It's like leaky kidney. And so proteins that shouldn't be able to get through are getting through and ending up in the urine. And so that's profoundly beneficial. The pH is interesting, although I'm still don't have a lot of clarity of what I like, because you say, oh, I want that urine to be alkaline, because an acidic body is not doing as well with kidney. And people who have kidney issues become more metabolically acidic just by the nature of those transporters not working with hydrogen ions, which is the acids. And so, if you're spilling more of those hydrogen ions in the urine, that could be a good thing. At least you're getting rid of them. If the urine's very alkaline, okay, maybe the whole system is doing well. I hardly ever do see a really dilute specific gravity. Sometimes, but more likely, I often see, whether kidney or not, people don't hydrate enough. Hydrate more.
So was I understanding correctly that if you do see an acid pH in the urine, that may not necessarily be a bad thing, because it could be that the body's getting rid of some of the acid?
Correct. But what I would do then is say, what are you eating? Animal food acidifies. Grains acidify. All right, let's do chronometer. Oops, you're doing too much. That's where the plant dominant diet helps to alkalinize. They've done studies, it's actually equivalent to using bicarb. But, people have metabolic issues that intensify that acidification. So I like using sodium bicarb. It's simple, it's cheap, it is amazing. The other lab test, by the way, that I didn't tell you about is uric acid is another one that's worth getting with kidney. And I've seen people have PTH, uric acid, potassium, all normalize using bicarb.
Wow. So we'll touch on that a little bit more as well. I want to talk about the phosphorus and potassium pieces. So you've said that phosphorus damages the kidneys before there are any detectable lab abnormalities. You talked about the fibroblast growth factor, or FGF23, is another way to explore issues with phosphorus. You've talked about phosphorus elevation as a tubule issue, and how tubular damage comes way before the glomerular damage. So what causes elevations of phosphorus in those with kidney issues? Is the phosphorus driving the kidney stress? Is it the result of something else that's impacting the kidneys and their ability to filter? Where is that phosphorus coming from? How do we address it? And can we potentially even use things like binders or detoxification support to increase our excretion of excess phosphorus?
Mm-hmm. So, just so first thing that's important is normal level of phosphorus is generally 2.5 to 4.5 milligrams per deciliter. Okay. So, and it's not on all panels. You have to ask for it, which is unfortunate, I think. However, with kidney issues, mid-range 3.5 and above, damage is happening already. So when they say, oh, the phosphorus is normal, well, yeah, but we have a different normal range for CKD. I have a blog post that folks can go look at, looking just at this lab thing. And it's critical to me because early on, I mean, I had an elevated phosphorus. This is part of why I got profoundly interested in it, because what's the problem? Cardiovascular disease. I mean, that's the huge thing. And another sidebar, here's just a set of statistics. Stage 3, I've had both 7 million, 13 million, a lot, big population. Okay, this is just one chunk of statistic. Stage 4, 400,000. What happened? They didn't all get better. They died. They didn't die of kidney disease. They died of other things, mostly cardiovascular. That's the reason that you get a lot of cardio labs. And they say 30 to 100 times risk of cardiovascular disease and demise with CKD. That's really important to know.
And that's because the elevated phosphorus is leading to a leaching of calcium from the bones, impacting the bones and increasing the arterial calcification.
That's one reason. That's only one. I mean, that's why I like ADMA and TMAO. Homocysteine is huge. I mean, and I see crazy high homocysteines. It's not that hard to fix. But if you don't order the test, you don't know. And one nephrologist said to me, oh, we don't really care about that. It doesn't really affect kidney disease. Yeah, I was like, well, but that's not looking at it in a whole body, holistic, pedestrian. Patients don't just have kidney disease, it's like, hello, I'm the one as a family doc who sees all of the organ systems, not just one. And so you can't separate it out. So all of those things really, really do matter.
And so where is that phosphorus mostly coming from? Is it coming from our animal food diet primarily, or is it building up because the kidneys are just not filtering, or a combination of both? Is it primarily exogenous or something that's happening in the body?
I think all of the above. I mean, first thing is we need phosphorus. Phosphorus isn't evil. Phosphorus is life-saving. It's just when it gets too high that it's like having, a bunch of terrorists going around causing trouble that you didn't even know was happening. And so, okay, what do we do? And there's a long conversation about this. Synthetic phosphates are in food. All this packaged junk that I tell people, you want to do good with kidney, you say no to that, Then it's like, can't do that. And that kind of phosphorus is absorbed systemically 100%. So there's an actionable change right there, easy. And that means you go to a potluck, you don't eat what people brought because you don't know what's in it. I mean, really, it's like I don't eat out much because it's sloppy. I have to really trust that. And I'm that strict. I think, that kind of like intent just helps to achieve this kidney success. Animal food is indeed high in phosphates, and it's absorbed about 80%, along with causing acidification, which also confounds the phosphorus issue. And early on, there's problems with the tubules in the transporters. And so when those transporters aren't working and, you can't excrete the stuff, you need to save the stuff because the body's confused. That's where FGF23 comes in. It's trying to get people to excrete phosphorus. That, on the other hand, when it's elevated, causes cardiovascular problems. So it's an adaptation that's not exactly the most functional adaptation, but, the body's a little Neanderthal. It does what it can.
So when someone has elevated phosphorus, would you ever use chitosan or bentonite? Do those have any roles in kind of helping to pull some of that phosphorus out of the body?
It's useful. So the last part of this, though, I want to finish that thought, is plant proteins come with phytates. So phytates are binders. And plant protein phosphorus is absorbed about 40%. That's one of the reasons that plant protein is of benefit in many, maybe all, most kidney cases. And so, yeah, there are strategies. One of the bioregulators, I think, has a role and is helpful. Fiber has a role. I love Acacia Senegal. I pretty much tell everybody to use Acacia Senegal. It's powder. It's in my tea. It doesn't taste bad. It doesn't thicken anything. Dump it in my cooking. I've kind of over years, I don't measure it anymore. I'm just like, dump it in because, I understand that. And just one sidebar is if you're going to use Acacia Senegal, you got to hydrate well because otherwise it'll clump up the gut. But it's quite amazing. Carnosine is another thing that's really helpful in this regard. But yeah, charcoal has a role. I used to be way more enthusiastic about bentonite until I found out that it can be a source of lead.
Yeah, and other metals as well, as I understand.
Yeah. And so I'm a little bit like, I think I have it in the book with this, the lead safe mama was the one who got me aware of this. It's like, ew.
Well, and I've actually reached out to one in particular, one of the more popular companies marketing bentonite clay, to ask for a COA, a certificate of analysis, and they refuse to provide one. So, they basically say, well, we couldn't provide it if it didn't meet the government requirements and all of that. But, and transparency was not there, which kind of was a red flag for me.
Yeah.
You say that sugar and sodas have to go. There's a number of, you can go to Whole Foods these days and find carbonated beverages with probiotics and stevia and monk fruit and things like that sound great, but they may still have phosphoric acid. Some have tartaric acid. Is that still a concern when we're talking about people having elevated levels of phosphorus?
Yeah. I mean, if you want bubbly stuff, we make lacto-fermented drinks, which we call fizzies, because they are bubbly, with things like begonia flowers and butterfly pea flower. They're delicious. They're wonderful. I have mine in a wine glass because I don't do alcohol, but I love the elegance of having the wine glass with dinner. And so there's ways around it. Maybe even just carbonated water that you squeeze some lemon in, and that's something I actually haven't looked into. What do I think? Is that safe with CKD? I shouldn't mention it because I don't know, but there's options, and it's like, cultivate some kidney-friendly teas. I have Chanca Piedra in here. I think I have Java tea. We've just started using Palo Azul, which are all like, and it's gorgeous. When you see it in the refrigerator, it's like bright, luminous turquoise. It's gorgeous.
Wow.
And that's going to be, the book called My Kidney Garden, because I'm growing a lot of these things. Cardamom is also in my cup, which is an incredible kidney friend. Everybody's put cardamom in their life. And so, it really is an intention. I was ridiculed by a group of nephrologists early on. Phosphorus doesn't matter. But they're seeing really sick people. Oh, it matters when they're really sick. And so my role is to say, well, in your guidelines, like you said, GFR 30 and above, see your primary care. Who doesn't know what to do? It's unfortunate. There are some functional nephrologists who are seeing earlier cases and doing beautiful work. There's a handful.
I'm glad that you're coming out with another book. At least then my workouts will be a little more even because I'll have one for each arm. So thank you for doing that.
I better make it as big.
Let's talk now about the high potassium or hyperkalemia. Why does potassium become high in chronic kidney disease? Is it because the kidneys cannot efficiently excrete it? And if that's the case, can we do something then to improve potassium filtering specifically? Is the approach to work on kidney health and overall body health more holistically? Do we need to reduce potassium in our foods and maybe even in our supplements? And then building on that, some people with fluid retention take diuretics And then because of the diuretics, they're taking exogenous potassium supplements, which to me seems a little bit of a counterintuitive given that the fluid retention could also be related to the kidneys. So, wondering what your thoughts are on that from a high potassium perspective as well.
Well, again, I had high potassium for a long time. And the biggest take home for me and for many people, sodium bicarb fixes it. Not without doing some of the lifestyle stuff, but I saw 5 nephrologists, not one of them mentioned that, but gee, my Facebook kidney patient group, people were like, no, you should be taking bicarb. So alkalinizing can help. First step. Some of that is diet. Again, the plant dominant diet offers, yeah, there's potassium, but it's alkalinizing, so it's a little bit balancing. I think currently the mindset in nephrology is don't worry about it, we'll just give you a drug. That's never been my mindset. I mean, I'm not against the drugs. There are times when they're life-saving, and I'm not like, never use drugs. That's foolish. However, I tend to want to try 20 things first that may be less traumatic to the general whole health. And so, what are the foods you're eating? Again, here comes chronometer.com. I mean, I started using that. And I was like, oh my God, you're getting it from the protein sources, you're getting it from the fruits and the vegetables. Well, you can come up with a number. I just kind of calculated. People have to work with either a doc or a dietitian to help. What's my budget? So my budget was 1,500 milligrams of potassium. And I was able to figure out what foods had that and more or less keep to my budget. I mean, when I was first sick, I was growing kale pretty high where I live. I had, unlimited coconuts, meaning coconut water, wonderful stuff, right? Really high potassium, papaya and mangoes and guavas and all these things. And so I was getting way too much. All right, it's gorgeous. I live in Hawaii. This food's not wonderful for me. Okay, deal with it, and really it's self-conversation. What's more important to you? You want to eat the stuff you want to eat, or do you want to feel good? Let me try to find stuff that I like eating that is lower in potassium. So that was when I discovered arugula, which optimizes nitric oxide, a whole nother conversation with kidney, and quit eating kale, quit eating Swiss chard. I love them, but I love my feeling good better. The lettuces, eggplant was a low potassium food. So I've cultivated the eggplant du jour because, it's like, and over time, when you can repair that and you're working on the whole kidney repair, it gets easier. And those transporters that are dealing with potassium are working better.
And what do you think about those people that have fluid imbalance, water retention, and are thus taking diuretics and then potassium because of the diuretics? To me, that doesn't make a lot of sense, but I see a lot of people that do that.
As an allopath who doesn't have the time, is not allowed, a lot of people work for corporations that dictate how many seconds you can spend with a patient, which is to me very challenging. I did that for 8 months and then bolted. You have somebody who's not eating well, they're stressful, their husband's not allowing them to buy the foods they need, whatever. I mean, many stories that I have in my file of patients' experiences. And those drugs are the lifesaver for them. In that culture, that's useful. Is it optimal? No, but their whole life isn't optimal. And what resources do we have? I did a lot of free medical care for people like that and spent the time, even stayed after, like, why don't you come at 5:30 and we'll sit and talk about your circumstances. Not everybody takes the time for that or whatever. So, there are diuretics that are botanicals, that are gentler. There's lifestyle changes to assist with that. I mean, realize that congestive heart failure which is causing a lot of this swelling in tandem with CKD, is an enormous story. And in more advanced cases, that's really common. That's what killed my mother. And, it was at a time her doctors didn't know what they were doing. I finally found some doctor who said, gee, she has a stenosis of one of her renal arteries. It's like, thank you. And essentially, her death was because of using a lot of diuretics to allow her to breathe. Her lungs were filled. She was walking around the house with a 20-foot wire of oxygen. And we recognized that the diuretics would relieve her quality of life, and the kidney decline is less stressful, less suffering. And so, there's not always they're not easy choices. Now, had we intervened 20 years before and had she been compliant, which I can say for my little cute mother was an issue, um, and that's where the willingness thing comes in. And that as clinicians, we need to be willing to take the time, because people come in disarray, whether they're stressed out, their poverty, their emotional poverty, whatever it is. It's like, where's the portal to help that person really want their life to be better? And that doesn't happen in 7 minutes.
So before we move off of the topic of potassium, there are electrolytes. Many of them have potassium. Many of them have sodium. We know that potassium and salt or sodium are potentially not a good thing in chronic kidney disease. So are electrolytes helping those people with kidney issues, or are they potentially making things worse by bringing more potassium and more sodium into an already stressed system?
Yeah, I mean, even people who have normal potassium levels, you don't want to overdo it. It's not a good idea, because you don't know, okay, you might be doing good with what you're doing. Too much is too much. Sodium, it's the same thing. None is dangerous. Some people overdo it. They're like, I won't put in. But excessive sodium can be compromised. I mean, especially with proteinuria, those people really need to back off on sodium and also protein, just to be protective. And you see resolution. Funny thing, things have gotten better. So I don't advise people to do electrolyte supplements. I mean, based on your labs, like, okay, if your magnesium is low, let's support that. Some people actually do have low potassium. I'm envious of every one of those people, because I'm like, okay, I know exactly what you can have, because they're all the things that I tend to avoid. And to be honest, over time, now I eat a little banana. I grow bananas. I haven't eaten them for 12 years. Recently, I actually ate a whole banana, the first time in a decade.
Wow.
It was like a big rush, like, oh, I'm eating a banana. But I just eat a little bit. I mean, I eat a little bit of papaya, which we also grow. And so, there's common sense, but I love lab work because it's a roadmap. It's imperfect, but at least you kind of know where am I at.
So let's talk then a little bit about vitamin D. We have first what most people are measuring, which is D25, which is the inactive form that's made in the liver, and then the active 125 vitamin D made in the kidneys. Some people suggest if the 125 is higher than the 25, that can be a sign of intracellular infectious burden. But most people aren't even testing 125. So when we're thinking in the context of kidney health, what is the role of the active 125 form? And would you, based on D25 and D125, ever supplement exogenous vitamin D in someone with kidney disease?
Yeah, good question. I've done both with people. So if you see a high 25, really generous 25, that's probably comfortable enough, more or less. I've done them both and found that the 25 looked good. The 125 was low. that's not good. So that's when, you would want to supplement. And you do it gently, because if you over supplement, then, all of those labs that I said, you see disarray with all of them. And that can be a consequence. And so, you don't want to overshoot with kidney, and yet it's so critical in this whole cycle with parathyroid and calcium and phosphorus. And
so you're not going to supplement based on just looking at D25. You're always going to be looking at the 125.
if the 25 is scary low, I probably start. First of all, I tell people, go hang out in the sun. And when I lived in Oregon, which is a little sun deprived, I had a home office and a very private little place that sometimes during lunch, I'd go pull off my clothes and lay in the sun for 10 minutes to get sunlight. Here where I live, I mean, you're getting sunlight all the time. And I've never had a low. I mean, in fact, one of the nephrologists was like, "Your vitamin D level is too high. Stop taking vitamin D." I'm like, "I'm a gardener." He's like,
So let's talk a little bit about the gut, the microbiome, and metabolic health. You say that everything gut is kidney. So there is a connection between kidney health and gut health, or what some call the kidney gut axis. So talk to us a little bit about how the microbiome impacts the kidneys. Are we talking about the beneficial organisms? Is there a conversation around pathogenic microbes that may lead to kidney stress, maybe through the production of endotoxins, for example? And in the book, you talk about eating fermented foods with every meal. So wondering what some of your more consistently beneficial tools are for creating more diversity in the microbiome, maybe in those that have a history of antibiotic use or just don't have a thriving biome.
yeah, I love your questions. Awesome. First thing to know is the uremic toxins. That's a thing. I mean, there's research about, like P-cressyl sulfate. Okay, there's been studies. That's the thing. But what I found in doing a bit of a dive into it, there's so many. We don't even measure them. So, okay, if there's that many, most people have some. There's toxins. I mean, and I can vouch for it. When I was really sick, I'd feel like I had the flu. Like I felt toxic, and I would just like have to lay down for the day. That's when I started researching, because I'm like, I can still move my fingers. And so those contribute to leaky gut. All of a sudden, these things that we should be pooping out are hopping over, getting in the bloodstream, and cycling through kidney. Some of them are very kidney specific and harming, inflammatory cytokine kinds of things that indeed, hit the kidneys and cause problems to the podocytes, to the tubules. There's scarring that happens around all those structures so that they're not flexible and moving well. And so, that's again my oncologist who is an integrative doc. Wait till you get a load of what the microbiome does to kidney, was all she said. She just tossed that to me as a challenge. And I spent a lot of time looking into this. It was Jenna Henderson, the naturopath, who said, start doing fermented foods, make sauerkraut, have sauerkraut. Most of the commercial sauerkraut is useless because it's been boiled, or the organisms are dead. You got to get the live stuff. And that's often very salty, too salty. So my husband has become a master fermenter, has spent a lot of time looking into this. You don't need any salt, but it comes out mushy. So you use some. And so, I think spore biotics are lovely for this. It's a nice way to supplement and just sort of some insurance in that regard. Not eating sugar, I mean, eating foods that's going to support a healthy microbiome is important. I mean, the bad bugs cause inflammation and, can be associated with nasty kinds of outcomes for kidney as well as the rest of the body. The inflammatory nature is always like the take home. Whatever's going to cause inflammation is going to challenge the kidneys to struggle. And so, you can do probiotics, and there are some very specific kidney ones. I haven't really decided that that's better than making it a lifestyle habit. We make soy yogurt because I choose not to do dairy for various reasons. Some of it is just way too salty, and it's animal, and it's one less thing to deal with. You make it with a plant-based culture, and so not hard to do. There's drinks, like I said, from kombucha to our lactose fermented drinks. We ferment things like eggplant and green beans. And when my husband makes sauerkraut, it has carrots and onions and garlic and herbs. So it's really like a multivitamin of fermented foods that's always there. It's present in all of it. But my latest exciting thing is I've been making garbanzo crepes. And it's the easiest thing in the world. A cup of garbanzo flour, a cup and a quarter of water, with the immersion blender, left out overnight, it starts frothing. It's bubbly. It's fermented. And so we get these sourdough. I don't do bread anymore. And so I have these lovely legume crepes that are like bread. And that's fermented. So there's a lot of options. The first thing is don't do stuff that hurts. Like I've looked into how do I avoid antibiotics when I might need them. And there are some wonderful strategies, including some peptides, many botanicals. Stephen Buhner's antiviral and antibacterial herb books are gorgeous and very useful. Many of those things are perfectly safe for kidney, especially instead of antibiotics. And you know what? If somebody really needs antibiotics, you do it anyway.
So when we're thinking about the uremic toxins, you mentioned P. cresol, which I think is one that can be an indication of Clostridia, if I remember correctly. And TMAO can also be an indication of some dysbiosis with some pathogenic organisms that are maybe creating that. So is there a scenario where we might be thinking about weeding the garden of the gut, so to speak, with antimicrobial herbs before we reseed it with fermented foods?
Interesting thought. I like that. I so personalize that it's like, I'm not sure when.
Stomach acid is another issue in chronic kidney disease. Some may need digestive enzymes or hydrochloric acid. You mentioned the intestinal hyperpermeability or leaky gut that can then result in some of these uremic toxins kind of translocating into our circulatory system. So what are some of your favorite tools? I'm going to guess BPC 157 is one of them, but what are some of your favorite tools for improving the health of the lining of the gut to minimize the impact of some of those toxins on the kidneys?
Yeah, well, SIBO is also enhanced with CKD. So, and so is oral health and the oral microbiome and periodontal disease. So, it's the whole thing from the top to the bottom, so to speak. And so I like the product Duozyme because it has, it's sort of one pill fits all kind of thing. Using digestive enzymes, I think is useful. It's helpful. It's like the stomach acid needs to be optimized. Stomach acid by itself will help with SIBO. And so that goes without saying. I like KPV as well as a tool for just keeping the gut free of sneaking in organisms. One thing that I used to love and I do not include in my kidney paradigm is licorice. But DGL can be a really helpful thing, if there's upper tract issues.
So if someone has diabetes, how much more likely are they to have kidney disease? And how does insulin resistance or metabolic syndrome correlate with or contribute to kidney disease?
Big, big time. Again, it's one of those cycles. It's like which came first, because kidney itself will exacerbate insulin sensitivity, resistance, and then, if the lifestyle doesn't accommodate little berberine here and there, that's happening. The other direction of it is, we know diabetic patients end up having nephropathy very often. I actually should look up, like, what's the statistic of how many. I don't know that, to be honest. But in my mind, if somebody is diabetic, I'm starting to work with them on that level, that, do you like your feet, you like your eyes, and you like your kidneys? Let's talk. And, that it's all very real. And so, it's another reason I like the bioregulators, because they're not pill for ill. You don't go, oh, you got this, here's this pill. It's more, what's the anatomy? What's the microanatomy of what's going on? So you can use a pancreas bioregulator along with a kidney bioregulator, along with some adrenal support, and attend to some of this stuff, along with, are you sleeping, eating, and exercising, kind of thing.
Cardiovascular disease risk in kidney disease is said to be 30 to 100 times higher. So let's talk about a portion of cardiovascular disease, the cardiovascular system, which is the endothelium, or the lining of our vasculature or blood vessels. You talk about endothelial health as a component of kidney health. Why is the health of the endothelium so important? And in the era of COVID, where endothelial inflammation seems to be almost universal, what are some of the tools that you found most helpful for supporting our vascular system? And are you seeing more kidney disease since the start of the COVID pandemic and the impact of spike protein?
Yeah. And that's a whole nother conversation, definitely. And I didn't. And so, that's been a concern for me. And the statistics are proving out that I'll stay home if I have to, kind of thing. And I do see often when I'm talking to people, how many times have you had COVID? How many of those shots did you have? Often there's consequences. And so, there are strategies to reduce that. I was just listening to the other Robin Rose, who's a gastroenterologist and has worked wonderfully around the COVID issue, is doing a little bit of a chat about using low dose naltrexone, which it was interesting to me in this regard. I like Endocalyx Pro as a product. I reviewed several of them, and it had the least kidney annoying ingredients. There's some things like fucoidan, which I really didn't know. I looked it up, and wow, it's quite useful for kidney. Okay. When the blood vessels get inflamed and damaged, again, there's compromise to kidney. It's a blob of blood vessels, and when they're not optimal, there's scarring, there's diminished constrictive circulation. That means the kidney isn't going to be able to do its thing, and there's backlog of toxins that feels like the flu. People just feel sick. And so, CoQ10, which is a crossover, I like ginkgo in this regard. I like ginger, and I love the bioregulators for blood vessels. Often I'll suggest people use them for prolonged period of time if there's any cardiovascular compromise.
I have had my fucoidan today. I've had my BPC 157 today. I've done the blood vessel bioregulator as well. So I'm learning a lot of things here from you. So, what is then, you touched on this a little bit earlier, but what then is the role of nitric oxide in supporting kidney health? And are we talking about improving iNOS or eNOS? Are there potential downsides to increasing nitric oxide? And Can BPC 157 have a role here? What about mouth taping? You already mentioned arugula. Talk to us a little about nitric oxide.
So my story with nitric oxide is I couldn't get mine to optimize. I was doing the little saliva sticks, reading about how nitric oxide is typically low in CKD. Well, there's another one to my list of things to be aware of for this cardiovascular assault of CKD. And I overheard Beth Shirley, who is one of our heroes in all of this. She's PharmD and nutrition PhD and the nitric oxide queen, as far as I'm concerned. She was telling somebody else who had trouble getting their nitric oxide to optimize about BPC 157. That was my portal. And I had this like, what? I want to know about this. That was the beginning. For me, it was actually the nitric oxide portal. And so it optimized, using BPC is amazing. And, it's interesting. I was just having a conversation with my Renology Associates practice partner, who's a cardiologist, who was talking. The conversation was just this morning, talking about how methylene blue can interfere and cause vasoconstriction, interfering with nitric oxide and the INOS. And so it's critical to have circulation to the kidney. Anything that's compromising and causing constriction of blood vessels without nitric oxide, that's the bad news. Can you overdo it? Of course. And with kidney disease, you're going to overdo anything. So, it's really a matter of just personalizing and paying attention. And, there isn't like reliable testing for this. Who knows if those little saliva sticks are accurate? It seemed like it because mine was low and then it wasn't with actionables, but it's interesting. And so, it depends on where the person is. If I have somebody in stage 2 and they have high blood pressure and, some circulatory issues, I might tell them to optimize their dose because their function isn't that bad. Whereas somebody in stage 4, let's have you use some BPC and let's start slow with nitric oxide support.
And do you find that mouth taping can help increase nitric oxide?
It's a factor. I actually have, personally, I've never tried it. I probably, quote, should. Ellie Campbell, who's a colleague of mine, an integrative family doc, talks a lot about the oral microbiome, which clearly affects kidney. And, so that's an interesting strategy.
I do it every night and have for years, and seems to help. Also, getting more breathing and air, and I monitor it with the Aura ring, and it's one of the things that's been helpful for kind of optimizing sleep. I want to talk a little bit about how homocysteine, which you mentioned earlier, fits into the endothelial conversation. If someone is on adequate methylation support, but doesn't seem to be seeing the homocysteine coming down into that ideal range of maybe 6 to 8, what are some of the other factors that might be, in the context of the kidney conversation, keeping homocysteine elevated? And what are some of the strategies that you might then think about beyond what we normally think about, which is methylation support with B vitamins and folate and things of that nature?
What I found was adding riboflavin seems to be the clincher for me and other people. I mean, I couldn't get it down. I was doing all the right stuff. I don't think betaine is a good idea in CKD. So, there are certain things that are like, well, maybe that's not a good idea, but.
So vitamin B2.
Yeah. Yeah. I mean, it's an interesting thing because, and I have notes on this and I'm not articulate enough to rattle it off that, some of the peptides actually do address homocysteine. Some of the bioregulators do as well. So, there's lots of strategies and it's just a matter of, first of all, believing that this is vasculopathy. If you have a high homocysteine, like, don't tell people it's not important if they have kidney issues. I mean, it's like, you saying this for? So
let's then touch on the mitochondria. You say that the tubules have among the highest number of mitochondria per cell in the body. You mentioned CoQ10 is commonly low in kidney disease. So do we see that optimization of mitochondrial function by itself improves kidney function? And are we talking primarily about exogenous CoQ10? Are there other mitochondrial optimizers that are more specifically helpful in the context of kidneys? Are we thinking about NAD or forms of B3 or NAD precursors like NR or NMN? And then is there a place here in the mitochondrial conversation for maybe not the peptide bioregulators, but peptides like MOTC or SS31? What are you thinking of as top tools in the mitochondrial conversation, which really then affects every aspect of body function?
yeah, I like the mitochondrial peptides. I, personally, and many other people tell me they've reacted to it in time, which was kind of disappointing. But SS31 is marvelous in this regard. It's advisable to include that in the plan. And some of the bioregulators also really will optimize. And so, we see the benefits, but it starts with monitoring.
So I guess that's a good point. I wasn't really thinking of the peptide bioregulators for mitochondria because I was thinking of them more as organ, gland, and tissue specific, but as part of their regeneration of whatever bioregulator you're taking, it is, from what I'm hearing, is having an effect then on supporting the mitochondria as part of that restorative properties that they have.
And things like, are you exercising? Are you sleeping well? All this really does. It's not just, a cool conversation, at a physiologic level. All of this contributes so that if you're doing this supplementation, why isn't it working? Oh, well, and there are dietary sources of CoQ10 and, that could be a whole nother volume of what to do.
To learn more about today's guest, visit renologyIsKidneySuccess.com. That's renologyIsKidneySuccess.com. renologyIsKidneySuccess.com. And don't forget to catch part 2 of our talk in episode 218, where we talk about infections and toxicants, carbon dioxide, uric acid, cognitive health, cellular senescence, the limbic system, and mental emotional contributors, dental considerations, treatment interventions, peptides and peptide bioregulators, and much more. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.